My name is Samantha Mann. I'm a consultant ophthalmologist at St Thomas's Hospital, and I'm going to be talking about the treatment of diabetic retinopathy and maculopathy. This diagram shows us how diabetes affects the retina. As a result of hyperglycemia from diabetes, there are various changes to the vessels and the vessel wall. Firstly, changes within the vessel, such as red blood cell changes and increased platelet stickiness, as well as basement membrane thickening, can lead to occlusion, and this results in reduced blood supply and ultimately new vessel formation and angiogenesis. These new vessels can occur on the optic disc and also elsewhere in the retina. Additionally, there are changes to the walls of the vessels with loss of pericytes. This causes a weakness of the vessel wall, resulting in microaneurysms. This then leads to increased vascular permeability and increased leakage or edema within the macular region. These cause exudates and result in diabetic maculopathy. I'm going to be talking about the treatment of retinopathy, maculopathy, diabetic retinopathy in pregnancy, and diabetic retinopathy with cataract. Diabetic retinopathy is a progressive condition. It starts as mild, non-proliferative retinopathy, or R1 as we call it in the UK, and then progresses over years to moderate and then severe non-proliferative retinopathy. These are known as R2 in the UK system. This then progresses over time to what's called proliferative retinopathy, or PDR. This is known as R3 active in the UK system. There are no symptoms from the mild or moderate or severe retinopathy. It's only once the proliferative retinopathy results in vitreous hemorrhage that any symptoms occur. These symptoms can present as black floaters in the vision once vitreous hemorrhage has occurred, or visual loss if it's a dense vitreous hemorrhage or a tractional detachment of the retina. Screening is essential to pick up these changes early before they become advanced and more difficult to treat. This is an example of mild non-proliferative retinopathy. At least one single microaneurysm can be seen in the posterior pole, or occasionally there are a few scattered hemorrhages in the retina. No treatment other than good diabetic control is advised at this level, and we would normally advise a 1-yearly follow-up. This is an example of moderate non-proliferative retinopathy. We see more hemorrhages in the retina. There are also a few cotton wool spots, which are the whitish lesions, and there are also what we call IRMA, or intraretinal microvascular abnormalities. These IRMA tend to look like spidery branch-like structures, which are flat in the retina. They are a sign of ischemia and often appear adjacent to cotton wool spots. Again, at this level of retinopathy, no treatment is advised other than good diabetic control. We would also advise a follow-up interval of about 6 months for further review of the retina. In order to diagnose severe non-proliferative retinopathy, we need to use the 4-2-1 rule. We also need to divide the back of the eye into quadrants through the optic disc. Here you can see a vertical line and a horizontal line dividing the retina into the superior temporal quadrant, the inferotemporal quadrant, the inferonasal quadrant, and the supranasal quadrant. We'll explain the purpose of this shortly. We use the 4-2-1 rule to diagnose severe non-proliferative diabetic retinopathy. The definition is either multiple blot hemorrhages, usually more than 20, in all 4 of the quadrants described earlier, or we see venous beading in 2 of the quadrants. There's an example of venous beading here, where you can see the venous beading changes along the blood vessel in the middle photograph, or the presence of ERMA, or intraretinal microvascular abnormalities, which is greater than this photograph 8A in any one quadrant. Either the 4 or the 2 or the 1 quadrant changes described here would be enough to define severe non-proliferative diabetic retinopathy. Patients with this degree of retinopathy have greater than 50% risk of progressing to proliferative diabetic retinopathy within a year. Studies such as the Panorama study indicate that no treatment is needed at this stage of retinopathy other than diabetic control. But because of the risk of developing proliferative retinopathy within a year, we would advise reviewing these patients every 3 to 4 months in case proliferative retinopathy develops. This slide shows examples of proliferative diabetic retinopathy. This is the most severe stage of diabetic retinopathy and needs treatment. The various features of proliferative retinopathy include new vessels or angiogenesis at the optic disc, known as NVD, or new vessels elsewhere on the retina, usually on larger caliber blood vessels, as seen here, or pre-retinal hemorrhage can occur when neovascularization causes bleeding within the eye, or vitreous hemorrhage if the bleeding then develops into the vitreous gel. The picture on the right-hand corner is of rubeosis. This is when blood vessels start to grow on the iris. Again, a feature of very severe diabetic retinopathy. We can divide proliferative retinopathy into high and low risk characteristics. If high risk characteristics develop, this can be very serious and needs immediate treatment. We define high-risk characteristics as new vessels on the disc greater than photograph 10A, which is shown here. This equates to new vessels approximately 1/3 to 1/4 of the area of the disc. If we have new vessels less than this area in association with any pre-retinal hemorrhage or vitreous hemorrhage, this would also be a high-risk characteristic. Also, if we have new vessels elsewhere, which is greater than half a disc area, with any vitreous or pre-retinal hemorrhage present, this would also be a high-risk characteristic. If any patient has evidence of high-risk characteristics, we would urgently treat these with pan-retinal laser photocoagulation, ideally on the same day, because these patients have a high risk of severe sight loss if left untreated. The treatment for proliferative diabetic retinopathy remains pan-retinal laser photocoagulation as the gold standard treatment. This stops the progression of new vessels growing further, and it can reduce the risk of severe visual loss by 50%. This treatment also reduces the 5-year risk of blindness by 90%. We can also perform macular laser treatment at the same time if needed, and this treatment is safe in pregnancy. When treating with PRP laser, it's important to know how much treatment to give. We use the ETDRS standard PRP area to give the correct dose. Various lasers are available. In our department, we tend to use the yellow 577 nanometers. But some departments use the green laser, which is 532 nanometers, or the Pascal laser. These are multi-spot lasers and make the application of the PRP treatment slightly easier. The original ETDRS criteria was 1,200 to 1,600 scatter burns around the peripheral retina, and these were a 500 micron spot size on the retina. It's important to know what your magnification factor of the lens you use is, so that you can calculate the correct spot size to dial into the machine. We commonly use a quadraspheric or a superquad that multiplies the spot size by 2. We'll talk more about that later. Duration of burns should be a 0.1, but we tend to use a shorter duration of burn with the newer lasers, which is more comfortable for the patient, between 0.05 and 0.1. The burn should be applied about 1 burn width apart. They should also be a light, moderate grey-white burn. The correct PRP dose should cover about 275 millimeters squared of the retina to get an adequate response. And don't forget, if you are using a smaller spot size, such as 400 microns on the retina, you do need to increase the number of burns. And this also applies if you are using a shorter duration of burn. Don't forget to give the patient good anaesthesia. This can be either topical or subtenons if needed. When carrying out PRP laser, it's important to know which lenses to use. We typically use a superquad or quadraspheric or Mainster 165 lens. These all have a ×2 magnification factor, which means that the spot size will be twice as large on the retina. A transequator lens can also be used, but this has a smaller magnification at 1.44. It is therefore important to adjust the spot size on the laser machine when using this different lens. When starting the pan-retinal laser treatment, it's important to give good anaesthetic to the patient. We would normally use tetracaine or oxybuprocaine. We would also typically do the laser treatment over 2 sessions, usually 2 weeks apart. We would normally start on the temporal border of the macular region. Following this, we would then carry out the laser treatment to the inferior retina. This is in case there is any bleeding. The third section would be the nasal inferior area, the superior nasal area, and then the superior temporal area. It is important to leave a space nasal to the disc, as this is where the temporal field is. It is also important to treat the temporal area 2 disc diameters from the fovea. This is an example of what the PRP scars will look like after applying the laser. Remember, you can treat up to 2 disc diameters from the fovea in the temporal region. It is important to treat right up to the arcades, superiorly and inferiorly, to provide adequate treatment. This is an example of one of our laser machines. This is the EasyRet machine. The wavelength is 577 nanometers and it's a yellow laser. This slide shows us how pan-retinal laser PRP treatment works. It is not fully understood, but we know that the PRP laser destroys the pigment epithelium and the photoreceptors in the outer retina. Overall, this reduces the oxygen demand of the retina. This also leads to reduced VEGF or vascular endothelial growth factor production from the retina, and may also allow increased influx of oxygen from the choroid. But what about anti-VEGF treatment for proliferative diabetic retinopathy? We know there have been 2 big studies recently, Protocol S and Clarity. Protocol S in 2015 and Clarity in 2017. These looked specifically at anti-VEGF treatment for proliferative diabetic retinopathy to see if it was superior to laser treatment. These studies did show that aflibercept and ranibizumab can improve retinopathy levels and reduce diabetic macular edema. They can also reduce the need for vitrectomy surgery and also reduce the visual field loss, at least in the short term. But in the Protocol S study, after 5 years, the visual acuity was no better in the anti-VEGF group compared to the PRP laser group. Plus, there is a very high cost of these drugs and a high number of injections are needed. Patients also do badly if they do not attend their appointments, and there is a small risk of endophthalmitis, which can cause severe sight loss in some patients. For these reasons, anti-VEGF is not a routine treatment for proliferative diabetic retinopathy. There are some indications when vitrectomy surgery is required as treatment. This is specifically when proliferative diabetic retinopathy is advanced. For example, there is attractional retinal detachment with fibrosis on the retina. This can be seen on the images and the OCT scan below. Also, if there is a non-clearing vitreous hemorrhage, this is often when a vitrectomy is required to improve vision and give good outcome. Vitrectomy surgery is often combined with endolaser, which provides a PRP treatment at the same time during the operation. Patients can do well following vitrectomy surgery. This slide shows the results of the study called Protocol AB, which looked at the treatment for vitreous hemorrhage, comparing aflibercept injections, i.e. anti-VEGF, to vitrectomy surgery and PRP laser. The study followed the patients for 2 years. The results showed that there was no real difference between the two groups in terms of visual outcome, but there was a faster recovery of vision in the vitrectomy group. Now we're going to switch over to the treatment for diabetic maculopathy. There are several different treatment options. These include observation and improved systemic control. Number 2, focal laser. Number 3, anti-VEGF injections. Number 4, steroid implant injections. Or number 5, vitrectomy surgery, especially for traction. We'll talk about these in turn. Questions we often get asked is, how do I know when to start treatment and which treatment should I use first? This will depend on 1, the location of the maculopathy, 2, the vision, 3, the response once you start treatment, and 4, other factors such as general health of the patient, travel, or any traction that's present. First, we'll talk about location. It is important to know where the diabetic macular edema is. Is it centre involving or non-centre involving? See the images below to give you an example of what they look like on the retina. This slide shows us how to assess the retina if the diabetic macular edema is non-centre involving. We need to know if it is clinically significant or not. This was defined by the ETDRS study group. Clinically significant macular edema exists if there is one of these 3 definitions. If there is retinal thickening within 500 microns of the centre of the macula, or if there are hard exudates within 500 microns of the centre of the macula, if associated with thickening of the adjacent retina, or retinal thickening that is greater than 1 disc area in size, if any part of this is located within 1 disc diameter of the centre of the macula. These diagrams give you an example of each type. We know that if someone has a clinically significant macular edema, focal laser treatment has been proven to reduce the 3-year risk of moderate visual loss by 50%, and we would offer these patients focal laser treatment. If someone has non-centre involving maculopathy, we can offer them focal laser treatment, which can be very effective. Don't forget, it can take up to 4 to 6 months for the laser to take effect, and it can be repeated 2 to 3 times, usually leaving at least 4 months between treatments. This is an example of what the effect of the laser treatment has on the retina. We use OCT scans, optical coherence tomography scans, to assess the response of the laser treatment. And we can see here that the thickened area in red has disappeared 4 months later, showing the effectiveness of the treatment. This slide shows the parameters we would use when performing focal grid laser treatment. We would typically use the area centralis lens, which has a magnification factor of ×1. That means that the spot size is not changed by the lens magnification. The spot size would typically be 100 microns. Duration typically between 10 and 30 milliseconds. Power starting at about 100 milliwatts. This may need to be adjusted once the treatment is started to get a response on the retina. It's important to treat under any microaneurysms and to perform a grid treatment over areas of thickening. You should expect to see light grey burns where the laser is applied. This diagram shows you with the red spots where laser would be applied in this scenario. Now we're moving over to talk about centre-involving diabetic macular edema. This is an OCT scan showing central thickening of the retina. This gives a cross-sectional view through the retina, and we can see the loss of the central foveal contour, intraretinal cysts, and exudates from the macular edema. It's important to note that we do not always need to treat edema if it is centre-involving. It is important to know what the vision is. If the vision is good, i.e. greater than 6/9, according to the DRCR-NET Protocol V study, we don't always need to treat these eyes. This study compared 3 groups: a group with anti-VEGF treatment, a group with laser treatment, and an observation group. All patients had to have a vision of 20/25 or better and no or minimal prior treatment for their maculopathy. And the results were looked at over 2 years. The primary outcome of the study was the proportion of eyes that lost more than 5 letters of vision after 2 years. The results showed that there was no real difference between the groups. Less than 20% lost more than 5 letters at 2 years in all groups. Therefore, it has been recommended that observation is all that is required if the vision is good, and you only need to add in anti-VEGF treatment if the vision drops by 5 to 10 letters or 1 to 2 lines. How do we treat patients who have centre-involving diabetic macular edema with visual impairment? This is when we offer anti-VEGF treatment, especially if the central macular thickness is greater than 400 microns on the OCT scan. Below you can see a typical OCT scan of someone with centre-involving macular edema, and the central number, 462, within the central circle is the average central macular thickness. The OCT diagram on the right shows you how swollen the retina is, and below are the various anti-VEGF treatments that are available to us, including aflibercept, ranibizumab, and bevacizumab. The diagram on the right shows an example of someone receiving an anti-VEGF injection. It is important to inject at least between 3.5 and 4 millimeters from the limbus, depending on whether the patient is pseudophakic or not. This graph shows the results of the Protocol I study, which was the first study to show the superior effectiveness of anti-VEGF agents, i.e. ranibizumab, for the treatment of diabetic macular edema compared to steroid treatment and laser treatment. You can see the superior effect and improvement of visual acuity with the ranibizumab group. All these patients were pseudophakic at baseline. We sometimes get asked which anti-VEGF agent should we use. This depends on what is available to you. The commonest ones that are used in the UK are aflibercept 2 milligrams or ranibizumab 0.5 milligrams. The newer agents, i.e. faricimab, which is 6 milligrams, and the 8 milligram aflibercept, are thought to have much longer acting ability, but these may not be routinely available and may cost more. The biosimilars are also becoming more available, which will help to reduce costs. There has been a concern with brolucizumab, as there have been some safety concerns about occlusive vasculitis being caused, which can be sight-threatening. Whichever anti-VEGF agent is used, these drugs can be highly effective. This is an example of a 71-year-old male with diabetic macular edema treated with 6 monthly injections of aflibercept. The effect can be very rapid, within weeks, and we see a resolution of the macular edema almost to a normal foveal contour. It is important that the initial treatments are given regularly, at least for the first 4 to 6 months. In this case, vision improved from 6/18 to 6/7.5, and the OCT map scan below on the right shows an improved central thickness, which improved from 513 to 243 microns over the course of the treatment. The Protocol T study was a comparison study of 3 different anti-VEGF agents. It looked at the difference between aflibercept, ranibizumab, and bevacizumab over the course of 2 years. The results showed similar gains in vision across the 3 groups. However, there was no difference between the aflibercept group and the ranibizumab group. The bevacizumab group did not dry the retina quite as well. These treatments are disease modifying and can reverse visual loss from maculopathy. They can also cause a reduction in the retinopathy levels, but they require high injection numbers. The visual gains with these drugs are considerable, over 50% with all 3 drugs. This table shows you the burden of anti-VEGF injection treatment over 5 years with the Protocol I study. You can see that the mainstay of injections are over the first 2 years, with an average of 8 to 9 injections in the first year, 2 to 3 injections in the second year, and ongoing the number of injections reduces, and many patients do not require any injections by year 4 or 5. Don't forget that there are some cases of endophthalmitis, but these cases are very rare. In patients with centre-involving macular edema, there is another option. There are some patients you may wish to consider a steroid implant for. These are examples of steroid implants, such as dexamethasone, which is known as Ozurdex, and fluocinolone acetonide, or Iluvien, which has a longer action over the course of 1 to 3 years. The Ozurdex implant tends to last 4 to 6 months. These can be effective, especially if a patient has had a recent myocardial infarction or stroke and may be a safer option, or if someone's had a vitrectomized eye, or if someone's travelling, as these only need to be given 4 to 6 monthly. It is preferable to give these in pseudophakic eyes, as they can cause cataract. and caution must be applied in glaucoma patients as they can cause a raised IOP. Moving on to pregnancy and diabetes, there are certain risk factors for progression of retinopathy. If women have greater retinopathy levels at conception, or if they've had diabetes for more than 15 years prior to the pregnancy, they are at greater risk of progression. In the UK, we tend to screen patients 2 to 3 times during their pregnancy. We also know that laser is safe for these patients, but anti-VEGF is not safe. Sometimes maculopathy with cystic changes, as seen in the OCT scan on the right, observation is all that is needed. Also remember that tropicamide eye drops are also safe in pregnancy. Lastly, I wanted to talk about cataract surgery and diabetic retinopathy and maculopathy. Cataract surgery can worsen retinopathy and maculopathy. Therefore, ideally, we want to treat these before the surgery. Both laser and anti-VEGF injections can be given before and after the cataract surgery to stabilise any maculopathy. We can also use anti-inflammatory drops such as Acular, ketorolac or nepafenac drops to be given post-operatively for 4 to 6 weeks to reduce any post-operative edema. So now we can summarise the treatment of diabetic retinopathy and maculopathy. For retinopathy, we only treat once patients develop proliferative diabetic retinopathy. This is when they require PRP laser treatment, or if there is vitreous hemorrhage present or traction, they will require a vitrectomy operation. Currently, we do not use anti-VEGF treatments routinely for proliferative diabetic retinopathy. Moving on to diabetic maculopathy, we need to decide if the patient has clinically significant macular edema or not. If not, they need systemic control improvement. If they do have clinically significant macular edema, we need to decide whether it is centre involving or non-centre involving. If they have non-centre involving maculopathy, we would treat with laser treatment. If they have centre involving maculopathy, we need to decide if they have good vision or not. If they have good vision, greater than 6/9, we would opt to observe them. If they have visual impairment, we would then offer them a course of anti-VEGF treatment, initially monthly over the course of 4 to 6 months, or perhaps offer them a steroid implant, especially if they were travelling or had a vitrectomized eye or had a recent myocardial infarction. We can also offer vitrectomy if there is significant traction on the macular area. I hope you found this lecture useful and help you in the treatment of your patients. Thank you.